Pandemic fiesta. My talk is regarding managing LDL cholesterol and what are the new avenues. Like we're going to discuss about that, and one of the latest molecule which has been introduced recently, that is Incl. So I'm going to talk about that and how we can manage challenges regarding the management of the LDL cholesterol. So regarding the history of DM and obviously association of the heart, because I'm a cardiologist. So Oskar Minkowski, with the help of Joseph von Mering, they discovered that diabetes is a pancreatic disease. That was the first time. What they did was they removed the pancreas from the dogs to induce diabetes. And diabetic dogs not only had high sugar but also developed rapid atherosclerosis in their arteries. Though this finding was overshadowed by the glucose story, but that was the first time that was reported that the diabetes is associated with the atherosclerosis and the heart disease. My scope of talk today is regarding LDL reduction, what is the need for that, different patients profile. I'll discuss about the case-based discussion, guideline recommendation, and about the inclisiran, how it helps. So we all know that globally, atherosclerotic cardiovascular disease is the leading cause of CVD mortality and the morbidity. 1 in 10 reported as a second MI or a stroke or CV death within first 100 days after experiencing the index myocardial infarction event. More than 10% event rate of death, MI and recurrent ACS reported within 1 year after the index event. So LDL cholesterol is one of the top modifiable CVD risk factors for the secondary risk prevention. And if we see real world settings, how the huge gap in the dyslipidemia management is there. So there are lots of real world data, meta-analysis, and which has shown that we have failed to achieve the LDL target goal in almost 70 to 80% of the times. So this is very, very important that we need to add something in addition to the statin to achieve that LDL target goal, and that is a real demand considering the real morbidity and the mortality of the atherosclerotic cardiovascular diseases present in the real world scenario. So a considerable gap in the management of the dyslipidemia still persists in the real world even after achieving the maximum tolerated statin therapy in the majority of the population, and that's why we need to treat aggressively and we need to do something more for the lipid management in addition to the statin therapy. And that's why there is a time to prioritize early combination therapy, not only the statin, but in addition to other molecule also we need to consider to treat specifically for the highest risk patients. And we'll discuss subsequently which are those high risk patients which we need to do aggressive lipid lowering therapy at the diagnosis and to achieve the LDL cholesterol to the target level faster. So a brief mechanism of action about the inclisiran. I think there was a discussion was going on about the PCSK9 with Dr. Manoria in Manoria's lecture. So PCSK9 is a villain. Basically, it degrades the LDL receptor in the hepatocyte. LDL receptor reduces the circulatory LDL cholesterol, and that's why it reduces the LDL cholesterol level in the circulation. But PCSK9 usually degrades the receptor, and that's why there will be the decreased uptake of the LDL in the hepatocytes, and there will be increased LDL level in the circulation. So PCSK9 inhibitors, there are two molecules available right now. There is one is monoclonal antibody and another is inclisiran. So inclisiran basically acts on the RNA level, and that's why it reduces the synthesis of the PCSK9, and that's how there will be less PCSK9 in the hepatocytes and less degradation of the LDL receptors, and subsequently there will be more LDL uptake by the hepatocytes and more clearance of the LDL from the circulation, and that's how it reduces the LDL cholesterol level from the circulation. So let's deep dive into some real world hypothetical cases regarding the lipid management. So Mr. Abhay, 39-year-old gentleman, BMI is 26, diagnosed diabetes 5 years ago. He's a very busy guy, software engineer, had anastomia and underwent angioplasty in his right coronary artery. His current medication is atorvastatin 40 mg, metformin and empagliflozin for the diabetes. HbA1c is 6.2 and current LDL is 154, which is definitely very, very high. So he needs a robust lipid lowering therapy, that does not increase LDL cholesterol in the presence of diabetes, and has a convenient treatment plan that fits his busy schedule. So 2024 ADS standards of care recommendation is that for people with the diabetes and atherosclerotic cardiovascular disease who are intolerant to statin therapy or who are non-compliant to statin therapy, PCSK9 inhibitor therapy in the form of inclisiran, that is siRNA, should be considered as an alternative cholesterol lowering therapy. So if we see the landmark trials, some of the landmark trials, inclisiran provides significant LDL lowering. That is a pivotal phase 3 trials in the individuals with the diabetes. This is a post-hoc pooled analysis, and it has shown that there is significant reduction in the LDL cholesterol from baseline, and you can see it here. Within 90 days the cholesterol level has reduced to almost 50%, and which was persistently low till 500 days of the follow-up. So it was there irrespective of the glycemic strata. It was there with the diabetes, pre-diabetic patients, or even normoglycemic patients. So it has achieved the reduction in the cholesterol LDL level more than 50% very early and for the sustained period of the study. Inclisiran first strategy, implementing inclisiran earlier in the treatment pathway significantly reduced LDL compared to usual care. So this was the study where it was inclisiran was compared with the usual care what we give statin therapy, and inclisiran was given in addition to the usual care, and what was found is that almost 53% significant LDL cholesterol reduction, and that was persistently achieved till 330 days. So LDL-C goal attainment with the inclisiran was almost 71.6% patients achieved the target LDL cholesterol less than 55 with inclisiran therapy. So this is the routine medications for the LDL cholesterol therapy. What we give right now is that the statin therapy is usually the pill burden, what we say 365 pills if you see the entire 1 year treatment data. Monoclonal antibodies, that is, somebody was asking in the morning, that is Repatha, which is available in the India right now, that is twice weekly, every 14 days injection. So it is almost 26 injection in a year, while siRNA, that is inclisiran, that is 0, 3 and every 6 monthly. So almost 2 injection in a year, through which we can achieve the LDL cholesterol in the target level. And that's why it is very, very important that the treatment adherence and the compliance is very easily achievable with this molecule, with the sustained reduction of the LDL cholesterol, very fast reduction and over the longer period of the time. So for this patient, inclisiran provides significant and the sustained LDL cholesterol lowering, 52% reduction LDL reduction in the patients with the diabetes and the pre-diabetic patients. It is convenient dosing regime, as we discussed. It is twice yearly injection only, so which is very, very convenient for any busy guy like our patient, and majority of the patients achieve the guideline recommended LDL cholesterol level. That is almost near to 80% of the patients achieve the target LDL level. Second case scenario, Mrs. Kalpana, 52 years old female, obese, BMI is 32, she had CKD, EGFR is 35, she experienced NSTEMI and underwent bypass for the multivessel disease. She is on atorvastatin 20 mg plus ezetimibe 10 mg combination, and her current LDL cholesterol is 120. So for a patient like her, there is a need for robust lipid lowering therapy that provides effective and consistent LDL lowering, and the therapy which is having proven efficacy and the safety in the renal impairment. So 2024 ABCD UKK recommendation, consideration of the inclisiran for secondary prevention in the people who fail to achieve the treatment targets, with evidence supporting its use up to stage G3B CKD. So inclisiran provides effective LDL reduction. This is a post-hoc pooled analysis of 2 phase 3 trials of almost 2,600 patients, and it has been found that inclisiran significantly reduced LDL from baseline to day 10, and that is irrespective of the MI status. Recent MI, definitely yes, more than 50%, but even the patients who have remote MI or even no MI, prior MI, it was consistently LDL cholesterol achievement in all this population. Another important thing is that Orion 9, 10 and 11 analysis, sustained LDL reduction was found with the inclisiran. 50.5% sustained LDL reduction with lower inter-individual variability, that is very important, from baseline to almost 500 days, and that has been found with the inclisiran. Almost 68% of the patients achieved an LDL cholesterol target level less than 70, and 52 achieved the LDL level less than 50 in this landmark Orion trials. Orion 7 has given some insight about the safety of the inclisiran in the renal impairment patients, and it has been found that though it is effective and the efficacy is remaining same with the CKD patients, it is also safe with the minimal side effects. So inclisiran provides effective and sustained reduction in the even in the patients with the renal impairment. So for this patient, again, inclisiran is one of the best molecule and best therapy to start with, along with the statin therapy, whatever she can tolerate. The next case, Mr. Ramesh, 60 years, male, BMI is 28, is hypertension. He has undergone angioplasty twice in last 3 years. His medication is rosuvastatin 20 milligram, ezetimibe 20 milligram. He is on antihypertensive bisoprolol, telmisartan. Blood pressure is okay, and LDL cholesterol is 80 milligram. So as per the current guidelines, still the LDL 80 is quite high, and it is not the right achievable target of this LDL for this kind of patient. So this kind of patients usually does not cause, he needs a lipid lowering therapy which does not cause the drug-drug interaction, and it should be proven and the safe for the older patients as well. So if we see inclisiran, it is very, very safe. There is no any drug-drug interaction, unlike the statin therapy or the other therapy, where we need to be worried sometimes regarding the drug-drug interaction. Inclisiran is not expected to cause any drug-drug interaction or to be affected by the inhibitors or inducers of the cytochrome P450 enzyme. So this is very, very important, and it can be used in combination with the statin therapy or other background statin lowering therapy. No safety concerns were identified from current switching between the evolocumab and the inclisiran. Evolocumab is a monoclonal antibody for the PCSK9. So we can even switch, and there is no interactions or any side effects with this molecule. Regarding the long-term safety in the high-risk CV patients, this is the analysis of the 7 trials. The treatment emergent adverse event, and that is basically the injection site reactions, which was found that it occurred at a similar rate over the both groups. Means there is no significant increase in that injection site problems. That is a data of almost like 10,000 patients here, exposure of the inclisiran. And it has been found that the very fewer events with the inclisiran versus the placebo as far as the TEA, that is treatment emergent serious event, that is the injection site reaction, which has been which is concerned. Inclisiran also associated with the I'll just take 1 minute more. It is also associated with ADA, that is anti-drug antibody. So inclisiran associated ADA was also infrequent, and there was no impact on the safety, efficacy and the safety of the inclisiran with that. So again, we have the huge data about the inclisiran exposure, and it has been found very, very tolerable, very safe, and minimal injection site, minimal risk of discontinuation because of the injection site reaction. So we'll conclude with last 2 slides. So this is a risk category based on the CSI 2023, that is Cardiology Society of India risk assessment. And we all know that we can divide the patients with the extremely high risk, very high risk and the low risk. And specifically for the extremely high risk patients, we need to reduce LDL less than 40. While very high risk patients, we need to achieve the LDL target less than 55. And these are the all guidelines which suggested that inclisiran is now one of the standard care for the LDL cholesterol reduction, and it should be considered in all the high risk and very high risk patients. So to summarize, LDL cholesterol reduction is a cornerstone of the cardiovascular risk reduction, with evidence showing greatest benefit from the early significant decrease in the LDL cholesterol. Starting combination lipid lowering therapy at the diagnosis at high risk patients reduces treatment delays, enabling large LDL cholesterol reduction within 4 to 5 weeks. 2 maintenance doses of inclisiran per year achieves effective and sustained LDL cholesterol reduction with a generally well tolerated safety profile as a complement to maximally tolerated statins or a monotherapy for statin intolerant patients. Thank you very much.